It's pre-holiday. Hey everyone, and welcome back to the channel. Today, we're diving deep into a topic that's absolutely fundamental for every dental professional, and even for anyone curious about their own oral health, the ADA Caries Risk Assessment. Now, I know what some of you might be thinking: forms, checklists, paperwork. But I promise you, by the end of this video, you'll see this framework not as a chore, but as one of the most powerful tools we have to prevent cavities and personalize patient care. It's all about shifting from a reactive drill and fill mindset to a proactive, preventive approach. So, grab a coffee, get comfortable, and let's break down how to master caries risk assessment. First, let's establish why this is so important. Dental caries, or cavities, is the most common chronic disease in both children and adults. Yet, it's almost entirely preventable. The problem is, not everyone has the same risk. Your patient who sips on sugary drinks all day is not the same as your patient who flosses religiously and has great saliva flow. Treating them with a one-size-fits-all approach just doesn't work. That's where the ADA Caries Risk Assessment comes in. It provides a structured, evidence-based way to figure out who is most likely to develop new cavities. It's like being a dental detective, piecing together clues to predict the future and, more importantly, change it for the better. This framework helps us classify patients into low, moderate, or high-risk categories, which then directly guides our clinical decisions. The ADA framework is beautifully organized into 3 key areas for each patient: disease indicators, risk factors, and protective factors. Let's start with disease indicators. These are the big, flashing red lights. They are the clinical observations that scream caries is active right now. There are 4 of them. 1. Any new cavities or lesions that have penetrated into the dentin, confirmed by radiographs. 2. Any new white spot lesions or enamel-only cavities seen on smooth surfaces. 3. Any cavities showing up on the chewing surfaces of teeth in the last 3 years. And 4. Any existing restorations, like fillings or crowns, placed in the last 3 years due to new decay. If a patient has even one of these 4 indicators, they are automatically classified as high risk. It's a non-negotiable. The disease is present and active, so we have to treat it aggressively. Now, let's move on to risk factors. These are the biological and environmental culprits that create a perfect storm for cavities to develop. They're the why behind the decay. The ADA lists 9 of these. Think about things like having a high number of cavity-causing bacteria. We can even do tests for this. Then, there's frequent snacking on sugary foods or drinks between meals, more than 3 times a day. We also look for deep pits and fissures in the teeth, reduced saliva flow, which we call xerostomia, whether from medications, radiation therapy, or systemic conditions. Saliva is our natural tooth-cleaning superhero, so when it's gone, the risk skyrockets. Other risk factors include exposed root surfaces, the use of orthodontic appliances like braces, and having a low socioeconomic status or limited access to dental care. These factors don't guarantee cavities, but they stack the odds against the patient. But it's not all doom and gloom. This brings us to the 3rd category: protective factors. These are the superheroes in our story, the things that actively fight against the cavity-causing villains. The ADA framework highlights 11 of these. The most obvious one is living in a community with fluoridated water. Using fluoride toothpaste at least once or twice daily is another big one. We also look for the use of a fluoride mouth rinse, or having professionally applied fluoride treatments in the last 6 months. Another powerful protective factor is the use of a prescription strength, 5,000 parts per million fluoride toothpaste. For some patients, using products containing xylitol, like gum or mints, 4 to 5 times a day can help. We also consider things like having adequate saliva flow and even having received recent dental care. The goal here is to see if the protective factors outweigh the risk factors. The balance between these 2 categories is what ultimately determines a patient's risk level, if they do and have any active disease indicators. So, how do we put this all together to classify a patient? Let's say we have an adult patient. We go through the checklist. Do they have any of the 4 disease indicators? If yes, boom, they are high risk. End of story. We move straight to a high-risk management plan. If the answer is no, we then look at the balance between their risk factors and their protective factors. If the risk factors significantly outweigh the protective factors, they are also classified as high risk. If the protective factors seem to balance out or outweigh the risk factors, they are likely moderate risk. And if they have almost no risk factors and plenty of protective factors, they are low risk. This professional judgment is key. The form is a guide, but your clinical expertise brings it to life. Now, let's talk about the little ones, because the framework is slightly different for children under the age of 6. The core concepts of disease indicators, risk factors, and protective factors are the same, but the specific items are tailored to their unique situation. For disease indicators, it includes things like having a mother or primary caregiver with active decay, which highlights the transmissibility of cavity-causing bacteria. For risk factors, we look at things like putting the child to bed with a bottle containing anything other than water, or having developmental problems. The protective factors are similar, focusing on fluoride exposure and regular dental care. The classification process is the same. Any disease indicator automatically means high risk. Otherwise, we weigh the risk and protective factors. This early assessment is critical because it allows us to intervene before major problems develop, setting a child up for a lifetime of good oral health. Once we've determined the risk level low, moderate, or high, what do we do with that information? This is where the magic happens. The risk level dictates our entire clinical management plan. Let's break it down. For a low-risk patient, our job is maintenance and positive reinforcement. We'll probably recommend bite-wing radiographs every 2 to 3 years, of professional cleaning, and continue to encourage their great habits like brushing with fluoride toothpaste. We're basically cheering them on. For a moderate risk patient, we need to step things up. We might shorten the recall interval for checkups to every 4 to 6 months. We'll take bite wings more frequently, maybe every 18 to 24 months. We'll definitely apply a professional fluoride varnish at their cleaning appointments, SPI. We might also recommend over-the-counter fluoride rinses and dietary counseling to address their specific risk factors, like frequent snacking. We're actively trying to tip the scales in favor of the protective factors. And for our higher-risk patients, it's all hands on deck. These patients need our most intensive preventive and therapeutic interventions. Radiographs are taken every 6 to 12 months to catch any new problems early. We're recommending prescription-strength 5,000 parts per million fluoride toothpaste for daily use at home. Professional fluoride varnish is applied every 3 to 4 months. We might perform bacterial testing and prescribe antibacterial rinses if needed. We provide extensive dietary counseling and maybe even seal pits and fissures that aren't yet decayed. The goal is to aggressively manage the disease, halt its progression, and systematically reduce their risk factors over time. The beauty of this system is that a patient's risk level is not a life sentence. A high-risk patient can become a moderate or even a low-risk patient with the right interventions and behavioral changes. That's why we perform this assessment at every single checkup. It's a dynamic process. It's also an incredible patient education tool. When you can sit down with a patient and visually show them their list of risk factors versus their protective factors, it just clicks. They can see exactly why you're recommending a specific product or a change in their diet. It empowers them to take control of their own health. It turns the conversation from "you have a cavity" to "let us work together to make sure you don't get any more." So, to wrap it all up, the ADA Caries Risk Assessment is an indispensable framework. It helps us systematically evaluate disease indicators, risk factors, and protective factors to classify patients as low, moderate, or high risk. This classification then drives a tailored management plan, ensuring that every patient gets the precise level of care they need to prevent disease. It transforms dentistry from a repair shop into a wellness-focused practice. 2. It's about being proactive, not reactive. For all the dental professionals watching, I encourage you to integrate this into your daily workflow if you haven't already. And for everyone else, ask your dentist about your caries risk at your next visit. It's a conversation that could save you a lot of time, money, and discomfort down the road. Thank you so much for watching today. I hope this breakdown was helpful and gave you a new appreciation for the science behind preventive dentistry. If you found value in this video, please give it a thumbs up. Do forget to subscribe and hit that notification bell so you don't miss our future content. Drop any questions you have in the comments below, and I'll do my best to answer them. Until next time, keep smiling and stay healthy.